Je suis très honoré d'avoir été invité de faire une présentation lors de cette prestigieuse conférence. Alors maintenant, parce que mon anglais est meilleur que mon français, je vais parler en anglais. So I am going to talk about the treatment of patients with co-occurring bipolar disorder and substance use disorder. Start out talking about the scope of the problem. So according to the National Epidemiologic Survey of Alcohol and Related Conditions in the United States, the lifetime prevalence of substance use disorders in patients with bipolar or individuals with bipolar disorder, 58% for alcohol use disorder, 38% for drug use disorder other than nicotine, and 44% for nicotine use disorder. When you look at the odds ratios, which is the level of increased risk of one event occurring when you know that another event is occurring, you see that alcohol dependence is nearly 6 times more likely in patients with bipolar disorder, and drug dependence 14 times more likely. So bipolar disorder has a higher prevalence of co-occurring substance use disorders than any other psychiatric illness. Why is this important? Because comorbidity is associated with a more severe course of bipolar disorder, with an earlier onset of mood symptoms, more frequent mood episodes, more aggressive behavior, more legal problems, and importantly, a higher rate of suicide. So I'm going to look at 3 specific drugs and their influence on the course of bipolar disorder. So I'll start with cannabis use, which is very common in patients with bipolar disorder. So people with bipolar disorder who use cannabis, in general, have less medication adherence, poorer social functioning, more severe mood episodes, a greater likelihood of psychosis, and poorer treatment outcome. Yet paradoxically, very often patients with bipolar disorder see cannabis as their treatment. And they often, I remember seeing a patient in a study that I was doing on the treatment of patients with bipolar disorder and substance use disorder. And when I went to see him, he said that the reason he was coming into the trial was because of his cocaine problem. And I said, well, let me talk to you about your bipolar disorder. Have you been taking medication? And he said, yes, I take valproate and marijuana every day. So, and that's not terribly uncommon for people to have that belief. So there was an interesting study that has been done actually and replicated, which looking at the implications of cannabis use on first episode psychosis. And they looked at 3 categories of individuals. 1, people who had used cannabis beforehand, before their episode, and then stopped. 1 was people who had used beforehand and had continued use. And the 3rd is people who had never used cannabis beforehand. The best outcomes were for those who had used cannabis beforehand and stopped as soon as they had their episode. And the worst outcomes was for those who continued cannabis use. So you can understand it that maybe people who were using cannabis beforehand may have had a less severe form of bipolar disorder than people who had never used cannabis, where the cannabis might have helped trigger the episode. The other people had more severe episodes. So if you stop, you can do pretty well. But if you keep using, it's very poor prognosis. What about tobacco smoking? So this, I think, there's some pretty interesting information. 1 is from a group therapy study, and I'm going to be talking about my group therapy study a little bit later. We had 61 patients with bipolar disorder and substance use disorder who were receiving group therapy weekly for 12 weeks. And we were interested in predicting who dropped out from the study. And we looked at a number of different factors that we thought might lead to dropout. And we had chosen our variables, and someone said, well, what about smoking? We thought, well, that probably won't make a difference, but we'll put smoking into the model as well. Turns out lower education and more recent episode predicted dropout, but far and away the best predictor of dropout was cigarette smoking with an odds ratio of over 11. So people who were smokers for whatever reason had a very poor outcome. We weren't the only ones that have found this. Michael Ostacher, who's currently at Stanford Medical School, did a study, 399 patients with bipolar disorder. 39% were daily smokers. Daily smoking was associated with an earlier age of onset of the first episode, lower global assessment of functioning scores, other lifetime substance dependence, and most interesting, nearly half of them had made a suicide attempt, twice as many as people who were not smokers. So there is something about cigarette smoking in people with bipolar disorder that's associated with some very poor outcomes. What about alcohol? So alcohol use disorder is also a risk factor for suicidal behavior in people with bipolar disorder. So in a very large study, 1,600 plus people with bipolar disorder, half of whom had a diagnosis of alcohol use disorder, those who had alcohol use disorder as well were significantly more likely, 25% versus 15%, had reported making a suicide attempt. What about neurocognitive effects of alcohol use disorder in people with bipolar disorder? So this was a study that was done by a psychologist named Boaz Levy that I was part of. So we were looking at patients with bipolar 1 disorder who were admitted to the hospital due to a manic episode. It was a fairly small study. We had people with bipolar disorder and current alcohol use disorder, people with alcohol use disorder in remission, and those who had no substance use disorder. Those with current alcohol use disorder were significantly more impaired in visual and verbal memory measures than those who had bipolar disorder only. And people who had alcohol use disorder, either current or in remission, had worse executive functioning than people who never had alcohol use disorder. So let's talk about treatment of patients with substance use disorder and bipolar disorder. I'll start talking about pharmacotherapy and then psychosocial treatment. So pharmacotherapy, this is pretty much the world's literature in successful treatment of patients with alcohol dependence and bipolar disorder. So this was a trial done by Ihsan Saloom when he was at the University of Pittsburgh. He's now in Miami. 24-week trial of valproate versus placebo in 59 patients who were on lithium. And the valproate patients had fewer heavy drinking days, where a heavy drinking day means 5 or more standard drinks in a day for a man, 4 or more for a woman. Less drinking on heavy drinking days, and there were no differences in mood symptoms. So sometimes people get this study confused and they think that it was a study of valproate versus lithium. It was not that. Everybody in the trial was on lithium. So it was valproate plus lithium versus lithium alone. Quetiapine has been studied for patients with alcohol use disorder and bipolar dependence by Sherwood Brown. They found no difference between quetiapine and placebo on alcohol use measures or in manic symptoms. Depressive symptoms were reduced in the quetiapine patients in the first 6 weeks, but I would say that you can pretty much call this an unsuccessful trial. So one of the sort of interesting medications that's been tried is citicoline. Citicoline increases incorporation of phospholipids into membranes and enhances the synthesis of structural phospholipids. It's sold over the counter. It may have neuroprotective and cognitive enhancing properties, and it's used in some countries for the treatment of Parkinson's disease after traumatic head injury, stroke, or vascular dementia. It may improve cognitive functioning. It may weaken the neurotoxic effects of the drugs that are abused. And the idea of improving cognitive functioning is that when you add behavioral therapy, people are more likely to respond to it, to learn better from the behavioral therapy. So there was a study that Brown did as well for citicoline, and Cocaine dependence and bipolar disorder started at 500 milligrams a day, went up to 2 grams a day. And the acetylcholine patients had a decrease in cocaine use based on urine screens, no difference in mood symptoms, and the effects of choline, of acetylcholine appeared quickly and then declined as time went on. So this is sort of a modestly effective medication with very little in the way of side effects, if any, so it might be something worth thinking about in this population. So given the fact that it's not clear that there is any particular mood stabilizer that's better than any other mood stabilizer for this population, one of the things that's important in choosing a mood stabilizer for this population is what's the likelihood that someone will actually take it as prescribed. And so we did a study, now this was done some years ago, in which we gave patients a list of a variety of different psychotropic medications they may have taken over their lifetime. And we asked them, over your lifetime, how often have you taken this medication as prescribed? And it went from never to 100% of the time. And we just looked at the percentage of, or the drug by drug, which were the medications that people actually took 100% of the time. We were particularly interested in lithium versus valproate, which at the time were the two medications approved for the treatment of bipolar disorder in the United States. And valproate was significantly more likely to have been taken as prescribed. What we were more interested in, though, was what were the reasons that people didn't take something as prescribed. And so when we looked at lithium, the primary reasons, the most common reason was physical side effects. The second one was I saw no need to take medication. And the third one was I wanted to use drugs and alcohol. Interestingly, for valproate, nobody picked physical side effects or saw no need. The most common reason that people didn't take it as prescribed was what they called a hassle, which meant blood tests. They didn't like the blood tests. The issue of that I wanted to use drugs and alcohol is an important one, because there are people who say, I think it's dangerous to mix my medications with drugs or alcohol, but it's not a bad thought, except they often don't then take the next step, which is to not take the drugs. They just don't take their medication instead. And so I once had a patient who said to me, yesterday I used heroin and I drank about a fifth of vodka and I used some cocaine and I was wondering, was it safe to take my lithium? So the problem is that people often come up with the wrong answer here, but I think it's important that people continue to take their medication or they'll end up with two problems, not one. One of the other interesting things when you talk about medication non-adherence is that non-adherence does not necessarily mean taking too little. It sometimes means taking too much. And so if you go to the bottom of this screen, you look at benzodiazepines, there's no surprise that 29% of people took more to get high, 29% took more because they were impatient waiting for the medication to work. So that's not limited just to medications that have what we think of as abuse potential, but people may, neuroleptics, people often took them more because they felt impatient, and sometimes to get high. They like the anticholinergic effects. Tricyclic antidepressants, the most common reason to be non-adherent to them was taking more. Someone saying, I know I'm supposed to take 50 milligrams of disipramine, but I was really depressed, so I took 200. These are the same people who will take 6 acetaminophen when they have a headache. And so the lesson I learned from this study is when I'm prescribing medication for a patient, and I ask them, are you taking your medication? And they say yes. Before this study, I would say, are you having any side effects? Now I always ask, how much are you taking? And I find out very often that people are taking a variety of different dosing strategies, some of which make sense, some of which make no sense. and they're perfectly willing to tell you about it, but if you don't ask them, they won't necessarily tell you because they don't think it means anything. They're just adjusting their dose. So I'm going to talk about psychosocial treatment. So the types of behavioral treatments for patients with bipolar disorder and co-occurring substance use disorders. There have been really only a few different trials for this. One is individual counseling, something called early recovery adherence therapy, and one called individual cognitive behavioral therapy, and then integrated group therapy that I'll talk about later. So early recovery adherence therapy, which was developed by Ihsan Saloom, who did that trial of valproate and lithium. The design of that is to increase medication and treatment adherence during the early phases of recovery from an acute mood episode. They integrate principles of motivational enhancement therapy and relapse prevention strategies. And they did one small trial of people, 34 patients with bipolar disorder and alcohol use disorder, who were either given this early recovery adherence therapy or a 12-step intervention over 12 weeks. And the people who got the early recovery therapy had less alcohol consumption and fewer depressive symptoms. Joyce Schmitz developed an individual cognitive behavioral therapy approach, 16 sessions, and she did a study of 46 patients with bipolar disorder and substance use disorder who either got medication monitoring alone or medication monitoring plus this cognitive behavioral therapy. And those who got the cognitive behavioral therapy had better medication adherence and fewer depressive symptoms, but no difference in substance use outcome. So integrative group therapy is something that I developed along with my team at Harvard Medical School and McLean Hospital, as funded by the National Institute on Drug Abuse in the United States. So the core principles of integrated group therapy is it's a cognitive behavioral model that focuses on parallels between the recovery and the relapse process of the two disorders. And so the general idea means that the same kinds of thoughts and behaviors that will help you in your recovery from one disorder will help you in the recovery from the other disorder. The same kinds of thoughts and behaviors that will get you into trouble from one disorder will get you into trouble from the other disorder. And I'll give you an example a little later. It's also, so think of that as parallels in the recovery process. We also stress the interaction, sort of a perpendicular, between the two disorders. So constantly saying things like, playing around with your medication is bad for your substance use. Using drugs and alcohol is bad for your mood. We have something that we call our single disorder paradigm. We tell people, don't think of yourselves as having two separate disorders that each require its own set of treatments. Think of yourself as having a single disorder called bipolar substance abuse. And the treatment for bipolar substance abuse is stay away from drugs and alcohol, take your medication as prescribed, monitor your moods, monitor your substance urges, get a good night's sleep, associate with the right people, so that we don't think of it, this is good for this disorder, this is good for that disorder, but this is good for your recovery, and this is bad for your recovery. And then we have something we call the Central Recovery Rule that we put on a bulletin board in the group that says, no matter what, don't use drugs, don't use alcohol, and take your medication as prescribed, no matter what. The second no matter what is for people who forgot the first no matter what. And a lot of the group really focuses on that. So what is integrated about integrated group therapy? So we have a check-in, and in the check-in, we ask people, did you use any drugs and alcohol this week? If so, on how many days? How was your overall mood? And did you take your medication as prescribed? So we have the check-in focuses on mood, substance use, and medication adherence equally. We pick topics that are relevant to both disorders. So topics might be dealing with depression without using alcohol or drugs, or what are your triggers? What are your triggers for depression? What are your triggers for mania? What are your triggers for substance use? And we emphasize that substance use is a trigger for depression or mania. Mania can be a trigger for substance use. We talk about the single disorder and the relationships and the similarities between the disorders and the recovery process are stressed. So some of the findings, we had 3 studies that were funded by the U.S. National Institute on Drug Abuse. In all of them, we compared IGT or integrated group therapy to either treatment as usual or standard manualized group drug counseling. All 3 studies showed a significantly greater likelihood of abstinence in the IGT patients, even though the group drug counseling was an abstinence-oriented treatment. There were fewer differences in mood outcomes. There were suggestions of improvement of mood, but not as much as the other. And it was cited by the National Institute on Drug Abuse as one of 5 examples of promising behavioral treatments for adult patients with comorbid conditions. So what do I mean by the parallels in the recovery and relapse process? I'll give you an example of this. So some people, I think, are probably familiar with the abstinence violation effect. So the abstinence violation effect basically is the following. If I have been abstinent, say, from alcohol for 3 months, and then I take a drink, I could say, oh no, I've ruined my sobriety, I may as well drink the whole bottle. So one of the things we thought about is, what is the parallel in bipolar disorder? And the parallel could be, I've been taking my medication as prescribed for all this time, and I just got terribly depressed. These medications aren't working. I may as well stop my medication. And so what's the same about these 2 things? Well, one of the things that is the same is the language. In both cases, you're saying I may as well drink the whole bottle. The other one, I may as well stop my medication. And so we call that may as well thinking. And that when you say to yourself, and I hope this translates into French, I'm not even sure. When you say to yourself, I may as well do something, you are about to make a bad decision because you are taking 2 alternatives that are very different. I'm going to stop drinking. I'm going to drink the whole bottle. I'm going to stay on my medication. I'm going to stop my medication. You're taking those 2 and you're saying, well, they're both sort of the same anyway. And so why would you say that? And you would say that because you feel hopeless about your ability to change. And most importantly, you feel hopeless that if you, and this is one of the common themes, these patients, I think, have what I call layers of hopelessness, where the first one is I feel hopeless that I can stop drinking. The second one, that I think is the most important, is I feel hopeless that if I do stop drinking, my life will get any better, because my life is so bad right now, I'll never get out of this. And so they think that no matter what they do, nothing will change. And that's why they think I may as well do this, I may as well do that, it doesn't matter what I do. So we talk about that, about may as well thinking, and the opposite of that is, so that is what we call relapse thinking. And it's relapse to mood disorder or relapse to substance use disorder. The opposite of that is thinking it matters what I do. And so we focus with people on trying to understand that everything they do moves them one step closer to recovery or one step closer to relapse. Every small step they take is going either in the right direction or the wrong direction. They may want to take 100 steps at once, but you can only take 1 step at once, and so we encourage people to move in the right direction. So what did we find? I'll just give you results of one of our last study. This was 61 patients. Half got integrated group therapy, half got group drug counseling. They all had current bipolar disorder and substance dependence. It was a mixture of different drugs and alcohol. They had to be on a mood stabilizer regimen, stabilized for at least 2 weeks. So what you see here is that their mood got a little better. So it went from 52% of people having a mood episode to 27%, as opposed to 57 versus 37%. So it was a trend toward better results. But if you look at abstinence, you see significantly better results in the patients with integrated group therapy. 71% versus 40% had at least 1 month abstinence. and almost 3 times as many people were abstinent throughout the entire trial. But when you think about people with dual disorders, if you're thinking about a good outcome, it's really an outcome in both disorders. So anybody that enters treatment for anything wants to know, when I'm done with treatment, what's the likelihood that I will be better? And so we defined better in this. We called it a good clinical outcome. It was actually a very good clinical outcome, which was that in its 3-month treatment, that in the last treatment, you were abstinent from drugs and alcohol and no mood episodes. And so what we found was that with integrated group therapy, over twice as many people were abstinent and no mood episodes, that they had this good clinical outcome, about 45% versus 21% of people who got group drug counseling. So the current status of integrated group therapy, it's been adapted for patients with psychotic illness. It's been adapted for people with general mood disorders. That's the way we are using it clinically at our hospital. And it's been adapted to many different settings, inpatient, residential, and forensic settings, where many of the check-in questions, if you're in an inpatient setting, asking, are you using drugs and alcohol, and are you taking your medication as prescribed, is really not the right question, but we can change it to, did you eat well? Did you get exercise? Were you honest with your treaters? People can adapt the check-in to whatever they want, or even not do a check-in. It's been used in a number of different clinical research and correctional settings, including someone that I met with who was doing it in Paris. And there was a book published, and we're currently working on an app for integrated group therapy. This is the book. It's a manual that goes through each of the sessions, and that's it. So thank you.
Thanks a lot, Professor Weiss, for your nice talk. We have now time for some questions. Yes, please. Voilà, qui souhaite poser des questions au professeur Weiss sur cette question importante de l'interaction entre les deux? What do we know on common mechanism of actions, or for example, neurobiological mechanisms, common mechanisms between bipolar disorders and substance use disorders that could orientate towards common therapeutics or pharmacological therapeutics?
Of what kind of therapeutics?
Pharmacological therapeutics,
pharmacotherapy.
Yes, please.
Okay. So in pharmacotherapy, we tend to use sort of standard mood stabilizers, very often either valproate or quetiapine. Those are the 2 most common ones that we use, or sometimes other antipsychotics, risperidone sometimes, but those are the 3 most common ones that we use. We also, it depends on, for the substance of abuse, it really depends on what they're using. So the 2, in terms of, we use naltrexone for patients with alcohol use disorder, as long as their liver can tolerate it. We will use buprenorphine or injectable naltrexone for people with opioid use disorder. So I don't think that the medication itself carries over as much from one disorder to the other as the psychotherapeutic does. I think for the pharmacotherapy, it really is 2 different disorders. For the behavioral therapy, we try to think of it as a single disorder. And the reason we came up with this idea of a single disorder is that patients who have two disorders almost always think of one of them as their real disorder and the other one as the one that other people tell them they have, but they don't. And so if you can convince them that they have the second disorder, they often think that they no longer have the first disorder, that's not so important. And we saw that in our group, and that's when I decided to use this term bipolar substance abuse, and people really liked that because they saw it as sort of their own special diagnosis that hits them, and that is unique to them that they could then focus on.
Question ici. Maurice.
Thank you for this very nice talk. We know that patients suffering from both disorders may require higher dosages of treatment. What is your experience regarding use of, you mentioned different treatments such as quetiapine, for example, of lithium or risperidone. Do you have to adapt the dosage and use higher dosages compared to patients suffering from bipolar disorder without substance use?
We're saying different stages of treatment?
Yeah, I wanted to know if you require, these patients suffering from both disorders require higher dosages of treatment.
Oh, higher doses, for example?
Yeah.
Not necessarily. Actually, not. I thought what you were asking at first, which I think is, it's another question, but in terms of different stages of treatment, this model of group therapy is not appropriate for someone, or is only appropriate for someone that at least is willing to consider that they have both disorders. So someone, particularly in a group setting, that says, I don't have an alcohol problem, that's not very, this model isn't good, and some places, including our own, have set up a preliminary treatment to get people to the point that they are able to accept that. They don't have to come in wanting to be abstinent. That's the job of the treatment, but they can't be in complete denial that they have that they've got a problem. But in terms of pharmacotherapy doses, I think, would you use standard doses? Yes, Nestor.
Yes, thank you, Roger, for your nice speech. Why you select 3 kinds of drugs and you excluded another drugs?
I'm sorry, say that again?
Why you select cannabis, alcohol, and no cocaine, and tobacco, and you exclude cocaine, for example? What if with some idea?
Oh no, we didn't exclude anybody.
Because you select 3 kinds of drugs in your initial of your presentation.
Oh, I just focused on those
okay.
Just as examples of particular topics of interest.
Okay.
That I picked as when I was reviewing the literature. These were just the things that jumped out at me that I thought were particularly interesting.
Okay.
We had, in our studies, about a third of the people were primarily cocaine users. So in terms of primary drug, about a third were cocaine, about a third were cannabis. I'm sorry, about a quarter alcohol, quarter cannabis, quarter benzodiazepines, quarter cocaine. Almost no opiate-dependent patients. We didn't exclude them. We just didn't see them.
Une dernière question. Non, je ne vois personne. Nous pouvons donc arrêter là. Thanks again for your nice talk.
Merci.